This conference will now be recorded.
All right, folks, so good evening. I'm glad you're here today. We're going to be looking at the cardiovascular system. And so this PowerPoint presentation that I put together, it has information from the Scott and Fong text, as well as from the Rizzo text, as well as additional information that's been given to give a very more complete PowerPoint presentation here, okay? So let's look at, as far as the PowerPoint, we may not finish it. I don't believe that we're going to finish this PowerPoint tonight, but we may. But I know for sure that we'll finish it up next week, as well as then add in additional information. So no worries. So let's begin here. And we're looking at, so we've actually had the opportunity in lab already to look at the heart. We've looked at the blood vessels and such. And so we're looking at, we have an idea, and we've got this information already with us as far as the anatomy of the cardiovascular system. So now we're going to just kind of like pretty much, there's going to be a review and there's going to be new information added. Know that on Thursday, the next 2 Thursdays, we're going to be doing the blood pressure. We're going to be doing blood typing. We'll be reviewing your tests, and then you'll have opportunity to review material that you've been looking at and studying for the first 2 labs. So lab 3 begins this Thursday and next Thursday, and then again 2 weeks from this Thursday will be your practical exam number 1. All right, so cardiovascular system, we're looking at the heart. We're looking at a pump, and it's actually 2 pumps, one going to, as you see in the below there, as far as pulmonary or pulmonic circulation through the heart, through the lungs, and then systemic going to the whole body systems. And we're looking at the blood. We've talked about the blood already as far as in detail with the previous chapter, and the blood vessels as far as the vascularity, what's going to take the blood that's being pumped to, whether it's to the pulmonic circulation or systemic circulation, and what's being carried within and where to. We'll also be going over blood pressure and such, right? What can affect blood pressure. So you'll see here, as far as the location of the heart, we call that area the mediastinum, right? So it's posterior to the sternum and primarily more left-sided, right? We have coverings of the heart. So you see here the pericardial sac. So this is a serous membrane. We have the fibrous and the serous pericardium. But take a look at here as we're looking at the heart. We're looking at the base of the heart being superior. We're looking at the apex of the heart being inferior. Recall that we also looked in the lab as far as the lungs. The apex is opposite, superior, and the base is inferior. Right? And we'll be going over the respiratory system pretty soon. So the layers of the heart, we have the epi, the myo, and the endocardium. Endocardium, inner portion, the myocardium, the muscular portion that actually contracts, and the epicardium, that outermost layer. And here you're seeing as far as those layers, and then you're also seeing the musculature right here, that myocardium, that thick myocardium, and you're seeing here the endocardium, which would be lining the walls of the heart. And you're seeing all 3 layers represented as well in this image, as well as the other image that you just saw. So we recall that being in lab, oh, hold on, let me stop what I'm doing here for a moment. Stop sharing. Okay, so you're having trouble with the screen, not able to hear anything. I'm going to shut down and try again. Yeah, the screen. All right. Is there anybody else? So I'm going to just bring everybody out for a moment. Is there anyone else that's having issues with my presentation? Are you hearing me? Do you see what's going on?
Yes, we can hear you.
Audio-wise, I shut down here. Yeah, so sometimes what you
It's
need
working
to do,
fine for me.
okay, good. All right. Yeah, so here's the issue. If you're having issues, you could reboot. Also, I'm plugged into, I'm not using my my Wi-Fi. I'm actually using a cable, at the Ethernet cable, right? That I'm directly plugged into my router. Okay, so that really can help as far as not having issues with being able to watch the presentation and such and hear what's going on. Just relying upon Wi-Fi, sometimes it can go in and out. and depending upon the demand in your home. So that could be an issue. All right, so let me just, so rely upon Wi-Fi, many times not the best option, but if that's the only option, you got to do what you have to do. All right, so getting back to our presentation here. So looking at the chambers of the heart. So we know that we talked about how we have the, at the base of the heart, we have the atria, the upper chambers, right? The superiormost chambers, and those are the receiving chambers, right? So they're receiving blood either from the systemic circulation, deoxygenated blood on the right side. On the left side, they're receiving it from the systemic circulation, right side of the heart, systemic circulation, deoxygenated blood, oxygen poor blood. The left side of the heart receiving from the pulmonic circulation, and that's the oxygenated blood coming to the left side of the heart, which will then in turn go to systemic via the aorta. So you see here we have then the lower chambers, those right and left ventricles, larger chambers. That left myocardium of the heart of the left ventricle is going to be larger in size than the right side, and it's pushing against greater resistance. So it's going to be larger than the right ventricle. As far as that septum is concerned, recall that I mentioned to you that as far as the atria is concerned, the fossa ovalis, it's a leftover from fetal circulation where there was an actually opening. It was called the foramen ovale. Foramen ovale is the opening between the right and left atrium. Okay, so that septum is there, and then we have the interventricular septum, inferiorward, separating the ventricles, and that's just that wall between the two ventricles. Right? But that fossa ovalis becomes the foramen ovale. I mean, the foramen ovale becomes the fossa ovalis. It closes up. That opening closes once the child is born within the first short period of time. Okay, within hours, it's closing up. Recall also that we looked at the ligamentum arteriosum. That is also a remnant of fetal circulation and the communication between really it's the pulmonic the deoxygenated blood going to the pulmonary circulation by the pulmonary trunk and the pulmonary arteries, and the communication between that and the atria. I mean, not the atria, the aorta. Okay, so you'll see here as far as we talked about that. Let's move on. So the superior inferior vena cava, right, bringing deoxygenated blood, oxygen poor blood to the right side of the heart. That coronary sinus is actually bringing deoxygenated blood from the actual circulation of the heart, or coronary circulation itself. We saw that we had the great cardiac vein, the small cardiac vein, and the middle cardiac vein all come together at a point, which would be the coronary sinus, and then the coronary sinus will then drain that deoxygenated blood from the heart into via the ostium, right? We talked about the coronary ostium for the coronary sinus into the right atrium. Pulmonary trunk and the pulmonary veins. You'll see here, so the pulmonary trunk has the right and left pulmonary arteries that are carrying deoxygenated blood to the lungs to become oxygenated. The pulmonary veins are returning or bringing back oxygenated blood to the left side of the heart, to the left atrium. The ascending aorta will, and again, this is what's going to be leaving from the left ventricle to the systemic circulation, carrying this oxygenated blood to the body, right? So we have that ascending aorta, aortic arch, descending, AKA thoracic aorta, and also the abdominal aorta, okay? And so we're looking at the anatomy of the heart, and we're seeing here as far as that we can view the actual valves, right? So here's the tricuspid and the bicuspid valves, right? And then we also have, as far as the aortic left side and the pulmonic semilunar valves, okay? And so here you're seeing as far as these are the pulmonary arteries taking deoxygenated blood away from the heart and to the lungs, and then we have the pulmonary veins bringing oxygenated blood to the left atrium. Okay? You're not seeing here, so you're not seeing in the atria, you're not seeing pectinate muscle, but you are seeing some papillary muscle here in the ventricles. Papillary muscles anchor the chordae tendineae of the tricuspid and bicuspid, or aka mitral valves. And then you're seeing some of the trabeculae carnae present here also in the ventricles. So here we have the AV valve. So I'm not sure if I really use that term with you, but atrioventricular. So, you know, what's going on is that you're having blood going from the atria to the ventricles via this atrioventricular valve. So tricuspid or bicuspid, aka mitral, and primarily in healthcare we use the term mitral. Okay? And those chordae tendineae are connecting the actual valves to the papillary muscle of the ventricles. Semilunar valves, the pulmonary and the aortic, or the pulmonic and the aortic. And here you're just seeing a little bit of a presentation as far as what they look like. Right? So here we have tricuspid, here we have bicuspid or mitral, and there we have the semilunar valves. And note with these semilunar valves, these are actually little cusps that are actually filling up with blood as the valve closes. So you're seeing here that as far as blood flow, we have, and you really need to practice this as far as you can write it out, draw a diagram. You need to know the blood flow through the heart so that we have superior and inferior vena cava bringing blood to the atria, right? And know what's going on as far as from the atria to the ventricles, from the ventricles to what valves they're passing through, and then to what blood vessels they're actually flowing through, okay? From chamber to chamber, from blood vessel to blood vessel. You need to know that the atria and the ventricles will contract together. So the atria contract, the ventricles contract, and when one group of chambers are contracting, the other are relaxing, okay, to allow for them to fill up. If both were contracting at the same time, then you just have blood would just then flow from one chamber right through the next chamber and then out, and there wouldn't be any chance for it to really fill up with blood in the second chamber. And so really then what's happening is that you're not getting enough movement of blood by doing that. So having one contract, by one relaxes to receive, and then that one contracts and the other one relax to receive. Yeah, it's quite a system. And again, two pumps. And so here's just a very simple presentation, seeing pulmonic and systemic circulation, and having an idea as far as what's going on with oxygen poor and oxygen rich blood, and knowing as far as also that we said there's a little bit of an exception to the rule as far as for the pulmonary arteries and the pulmonary veins, what they're carrying as far as oxygen rich or oxygen poor blood. So I recall that in ANP1 that I have discussed with you all as far as, well, those that were students of mine, but I always do it every semester as far as in histology, we're looking at cardiac muscle and we're seeing how it's different from skeletal muscle. So cardiac muscle, there's branching taking place, branching cells, 1 to 2 centrally located nuclei, right? Instead of more on the periphery of the fibers, the muscle fibers in skeletal muscle. Also, that there are these dark, so you see striations, so it's striated as is skeletal muscle, but you're also notating that we can see it, it's very easy to spot. You'll see these dark lines present also, and these are these intercalated discs, right? They allow for cell-to-cell contact and allow for communication of the muscles of the cardiac muscles so that the chambers will, in unison, atria contract, ventricles contract together. And so they contract as single units. Very important to remember. I just gave you there as far as seeing the desmosomes and the gap junctions also will be these cell-to-cell contacts within the tissues. Now, this is important as far as, well, it's all important, but this is important as far as the conduction system of the heart. Excuse me, one moment there. All right, so as far as the pacemaker of the heart, where the action potentials will initiate and begin would be at the SA node, sinoatrial node. So the SA node to the AV node to the AV bundle, aka also known as the bundle of His, then to the bundle branches and the Purkinje fibers. Right? And you're going to see how we have this progression of this action potential passing through the different chambers, right? And allowing for contraction to take place. I'm going to share with you all a link to a video that I think you'll find very interesting. It's not a video I've made, but it's a video that is very good as far as linking an EKG with actually visually watching what takes place as far as the blood flow and as far as the electrical activity of the heart. So I will post that for you all. Okay, I think it'll help to make things very more real to you and really understand as far as what's going on with the conduction system of the heart. Please know that you're going to have to memorize this as far as knowing where it goes. So the progression is SA node, AV bundle, aka bundle of His, to the bundle branches, right and left side, then to the Purkinje fibers. So here we're looking at then going from SA and AV node into that bundle, and that bundle then will then send action potentials through the ventricles. So here we see, here's the SA node, okay? That's the pacemaker. It's going to send action potentials then throughout the upper chamber to the AV node. Here's the AV bundle, aka the bundle of His, and then it's going to go through the interventricular septum and then through the myocardium to the both chambers of the lower chambers, the ventricles. And again, like I said, by watching that video, and it's an animated video, it's not very long, but you'll see what's taking place as far as how it's passing through the areas as far as the electrical activity, which in turn stimulates the contraction of the myocardium. So the EKG, ECG, right, same AK, also known as, this electrocardiogram, we're going to see that here. So here we have, you've all seen this. You've all seen this on TV. You might have actually seen this in person by visiting someone in the hospital who's a cardiac patient, right? We're just going to kind of go over this a bit there. And you'll see as far as the depolarization. So recall that you have to have depolarization as far as when we were talking about muscle contraction prior to actual contraction, right? So again, these are electrical events. So action potentials are being produced. And so you'll have depolarization taking place at the P wave, right? And then you're going to have then this contraction taking place at its peak. So you see here, so here we go. So during this P wave right here, right? So you'll have that taking place. Then you're going to have repolarization taking place during this event here, during the QRS. That's where repolarization of the atria will take place. And this is where depolarization and contraction will take place of the actual ventricles, okay? So the P wave, atria, QRS, think ventricle, and repolarization of the atria. And then the T wave, which is the last area there, would be then ventricular repolarization, okay? So again, I'm going to share a video with you that'll help. You'll see as far as an animation of the heart receiving blood flow and blood flowing through, contractions, blood movement, and then you're going to see as far as the EKG, the ECG, also moving throughout that whole cycle, and it combines everything together. And I think it'll be very good for you to see that, and easier for you to understand by looking at the two combined together there. Terms systole and diastole, right? These are terms that we use in order to describe contraction or relaxation, okay? And so we know that with any kind of muscle, we have contraction and then we followed by relaxation. And know that with the cardiac muscle there, we have this going on from very early on in the fetal development. Within the first month, we're having contractile cells very soon are developing, and then we'll have then the actual heart beating throughout all of the circulation, and it doesn't stop until the day that we pass from this life to whatever's next afterwards, right? So you'll see here as far as, so knowing these terms, systole and diastole, very important. And know that as far as atria contract, ventricles relax, then we have ventricular contraction and atrial relaxation. Now, these terms here, you just need to have an understanding as far as thinking about what's taking place first, as far as, so what we're going to do is at the end of the QRS complex. So we're looking here, here's the QRS, right? So we have then atria contraction, ventricular contraction. Then what are we going to have? We're going to have then a whole reboot of the musculature, and there's going to be relaxation taking place. And then we're going to have then the atrial contraction and then the ventricular contraction. So as we're looking at here, so you have to have then ventricular muscles contract. There's an increase in pressure in the ventricles, which as a result in the atrioventricular valves closing, which would be the tricuspid and the mitral valve, right? Those are the AV valves, the valves between the two chambers, right? Between the atria and the ventricles. Okay? Then what will happen is that, so we have there the muscles contract, increase in pressure in the ventricles, the valves close. Beginning ventricular systole, right? So systole is contraction. Semilunar valves, which were closed, now they're going to what? They're going to be, we're closed in the previous diastole and are closed during this event. Now they're going to then what? Ventricular pressure will increase and greater than the pulmonic pressure within the pulmonary trunk and the aorta, and that's going to then in turn push those semilunar valves open. So the pulmonic and the aortic valves will open. Blood is going to be ejected from the ventricles. And then the cycle then begins, because then what's going to happen? So then you're going to have blood entering into the atria, right? So we're going to repolarization and relaxation of ventricles. Ventricular pressure will drop. Semilunar valves close, right? So they assume semilunar valves, those aortic and pulmonic semilunar valves, they close. Blood flowing back to, so recall you saw the pictures of the semilunar valves. They're like cusps, they're like a little cup. And so they will fill up with blood and help to further close those valves so that no more blood is going to be leaving the ventricles, okay? AV valves are also closed so that they're going to, because those chambers, the atria, are both going to be receiving blood, filling up. So passive ventricular filling, atrial pressure rises above the ventricular pressure, resulting in the opening of those AV valves. Blood's going to then flow through. Blood flows into the relaxed ventricles. Atria contract, completely releasing the blood from the atria into the ventricles, and then valves will close and the process will begin. So here you can see, folks, as far as what's happening as far as blood entering into chambers, then blood being ejected and released from the chambers. As you look at this, I'm not asking you to commit this to full memory, but I want you to have an understanding of what's taking place, where the blood is going from, what area to what area, what vessels it's going from, what's happening as far as the conduction of the SA node to the AV node, the AV bundle, or the bundle of His, then the bundle branches into the Purkinje fibers. You'll need to know as far as what's taking place with the aortic and the aortic and ventricular depolarization and repolarization on the EKG, right? And that's why, again, I'll share that video and that'll be helpful, and I'll answer any questions you have after you've watched the video, okay? As far as, so let me stop for a moment here. Are there any questions right off the bat there? So answer any questions or.
May I ask a question?
Yeah, sure, go for it.
Okay, so, reading through this, the first thought that kind of came to mind when I was reading, obviously this is muscles firing, so it's the same thing as any, it's like a cardiac neuron per se, right? So when we're talking about the repolarization, valves close via blood flowing back to relax ventricles. Does it partially have to do with, like, for example, like the increase in the volumetric pressure of one of the chambers, right? Like in that chamber, in that blood, it carries different minerals like sodium, potassium, calcium, whatever it may be, right? Is that have to do with that repolarization cycle? So that influx of it, that influx of those minerals and like flowing in and out of the cell walls to create that action potential? Because, or is it,
It's
do you know what
not
I'm
so
saying?
much.
Are we
Yeah,
just,
so I would tell you it's not because of what's in the blood.
okay,
That's not
so it's
really. Yeah,
really
that's
just
not.
when we're talking about repolarization, we're quite literally just talking about the peak dropping, coming back up. We're not going so
Yeah,
much
yeah,
into the
yeah,
cell
indeed. Yeah,
firing.
so that's, yeah, really we're talking about the electrical events in the nervous system
Right.
that's present within the cardiac muscle and so, yeah.
Okay.
So that's
Yeah. Okay.
really what we're
Yeah,
talking
my
about. Yeah.
brain was crossing over a little bit. I just need a
Oh, it's
good
okay.
separation.
Oh, it's all good.
Thank you.
Yeah, no worries. No worries. Okay. Anybody else have anything? Any question or comment? All right. Let's hide everybody again. We'll share my screen. All right. So when we think of heart sounds, you know, you hear that do, 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 right? You're thinking of the valves closing. Okay, so it's the closure of the valve. It's not the opening and closure of the valves. It's only the closure of the valves that actually creates that sound. Okay, so know that there, right? Please. So that lub dub actually as a result of AV valves closing first, and then the semilunar valves, which would be the aortic or the pulmonic and the aortic, right? And here we can see as far as where you'd be listening with your stethoscope in order to hear what's going on with the different areas. And so as far as the aortic, tricuspid, pulmonary, and mitral regions. All right, so systemic circulation, so it's going through the whole body, right? So we're beginning, and really systemic circulation, one moment. She's a little doggy, but she can make quite a bit of racket. All right, so systemic circulation, this is where we're taking this oxygenated blood and we're sending it through the whole body, right? And so all the blood that's leaving the left ventricle, right, it's entering into the ascending aorta, and really the first area of the body that receives this freshly oxygenated blood would be what? Really, we're looking at, as far as entering into the heart, it's going to be the actual heart itself, right? So this is really one of the key issues which helps to allow for, which really provides the perfect environment for the heart to continually um, beat, right? Have these contractions, relaxations, but not have it totally relaxed, right? Because we need that blood flow continually pumping throughout the body. So it's going to be the actual right and left coronary arteries, right? So those are branching directly off of the ascending aorta. Those are the first branches, okay? Sending that oxygenated blood right to the heart itself, and then as going the ascending, right, go through, continually ascending, going into then the arch, and then we're going to have those branches from the brachiocephalic, the common carotid, the subclavian, right, and then going through systemic circulation. So, and just like I mentioned there, as far as the coronary circulation, so it's bringing this oxygenated blood to the heart muscle itself, the right and left branch of the coronary artery. Exchange of oxygen and waste occurs at the capillary level, right? And know that. So those capillaries are the very tiny vessels that are thin-walled and allow for movement of the oxygen, movement of the gases of CO2, and movement of nutrients, and also movement of waste entering into the blood. And then, as we talked about earlier there, as far as that, the great, middle, and small cardiac veins, draining, all of them draining into the coronary sinus from coronary circulation, and then passing through the ostium and entering into the right atrium. As far as portal circulation is concerned, so this has to do with, it's a branch of general circulation, and think of dealing with the the digestive system and the liver in particular. Okay, so veins from the pancreas, stomach, small intestine, colon, spleen empty their blood into the hepatic portal vein, which goes to the liver. The liver ensures that the blood's glucose concentration is kept within a relatively narrow range, and know that excess blood glucose, right? We're storing it as glycogen. They're storing it primarily in the liver, but also in the skeletal muscle. And know that the liver really very important as far as production of, synthesis of the plasma proteins, which are present within the blood and very much involved in aiding in the carrying of hormones and such throughout the body and other types of chemical messengers. We'll talk about that more when we look at digestive system function. Okay. But here you're seeing as far as, so with the this is the splenic vein. You're seeing the venous and the portal circulation here as far as going from the different aspects of the digestive tract and entering into the liver. So very important. Remember, this is then inferior vena cava, right? Recall that we have, and it's really, remember that it's not, as we think of arteries, you know, going from proximal to distal, really we're going from venous circulation from distal to proximal back to the right side, right side of the heart, right? So very important that we're thinking that direction. So, you know, you're having here as far as common iliac veins, and then you're going to have internal and external iliac veins, right? So we're draining it from, and really as far as from the lower extremity, think we have here as far as the small, great, and the small saphenous veins that are bringing it up from the extremities into the iliacs, up and then into draining into the inferior vena cava. All right, so as far as pulmonary circulation, right? So the right side of the heart, that pressure that's going to be leaving of the blood pressure is not going to be as powerful and as strong and as high as the left side of the heart. Okay, and really know this as far as throughout all the circulation, the lowest pressure within the cardiovascular system would be entering into the right atrium, and the highest pressure is going to be exiting the left ventricle. Okay, that's the lowest and the highest pressure as far as blood is concerned throughout the body. Okay, and this makes sense, right? So it's not just when you hear and you think, oh well, where would the lowest pressure be? Well, it'd be in the capillaries. No, it would not. It's going to be in the venous system. Okay, so the inferior superior vena cava going to have bringing the lowest pressure to the right side of the heart. The greatest pressure is going to be exiting from that left ventricle and entering into the aorta. Okay? And you'll know that in fetal circulation, as far as pulmonary circulation, it's different. And we talked about that as far as having a little bit of a difference as far as the opening of communication between the atria, the atrial chambers, with the foraminal valve, and also with the ligamentum arteriosum, which would that remnant of that fetal circulation, that communication between the pulmonary arteries and the aorta. So here we're talking about, oops, right there, okay? So this obtains oxygen and nutrients from the mother's blood, not through its own lungs, right? Because we're not oxygenating the blood just yet, as a result of respiration. And we'll, as far as the respiratory system, we'll be talking about how does oxygen enter into the body, how does CO2 leave the body. We'll talk about pressure changes of what's taking place as far as whether we have, and it's a gradient, whether it's high or low pressure, we're going to have gases move in and out of the respiratory system. So we'll get into that a couple chapters in, okay, toward the latter part of the semester. Let's see here as far as, so, and this is important also to know, right? So we talked about this a little bit as far as when we're looking at the blood. We mentioned about erythroblastosis fetalis as far as what can happen if mom is Rh positive, mom is Rh negative, mom is Rh negative and the baby is Rh positive. So really the first pregnancy, it's not really a problem. Other than that, it's going to be a problem for subsequent pregnancy. okay? So it's only when the birthing process occurs is where there can be more interaction and interactivity between fetal blood and the mother's blood, okay? This all takes place via the placenta, okay, during fetal circulation of the development of the fetus of that baby. So terms that you need to have an understanding of and really just memorize these terms. It's important. Now, heart rate, we get that, right? We understand heart rate, number of times the heart beats per minute. You know, we can all take a pulse. You know, the radial pulse is a very common one, carotid pulse, right? We can all do this and it's not too difficult. We have an understanding of that. But the term stroke volume, the amount of blood pumped during each heartbeat, okay? So each heartbeat will have the amount of blood, that's called the stroke volume. Now the cardiac output, the CO, is a matter of, so that equals the stroke volume, how much of the blood is pumped during each heartbeat, and then the heart rate. So whatever that may be, that gives you your cardiac output. Now, the mean arterial pressure is the average blood pressure in the aorta. So we take that MAP, that mean arterial pressure, and we take the CO times what? The PR, which is total resistance, right, against which blood must be pumped, okay? Peripheral resistance, this PR is the total resistance against which the blood must be pumped. And know that the blood vessels that the blood is going from the chambers to the blood vessels, it's that resistance that's provided by those blood vessels that will actually then create more of an issue as far as having to push through. So the left side of the heart pushing again into the aorta, right, is there's going to be much more resistance coming from the aorta than there would be as far as then going into the pulmonary arteries, pulmonary trunk and the pulmonary arteries, okay? Less resistance, again, less pressure, right? So right side of the heart, a lesser pressure system than the right side of the heart, lesser pressure system than the left side of the heart, okay? Now, we've been discussing and we've talked about in the beginning of the semester and the end of last semester regarding parasympathetic, sympathetic, and we have an idea. So we know that. You just know off the top of your head that sympathetic is absolutely going to be increasing. So preparing the body for action, so an increase in heart rate, force of contraction, blood pressure, these are all going to be elevated as a result of sympathetic stimulation. As far as parasympathetic stimulation, right, which the body should normally be under more of a parasympathetic influence, we're going to have a decrease in heart rate, okay? You can see there ACH, acetylcholine secreted, which hyperpolarizes the heart. And so it causes a calmness to occur so that we're going to lower the heart rate, which will decrease cardiac output also, okay? Now, sympathetic stimulation as far as with epinephrine, norepinephrine, okay? This will increase cardiac output. Like I said, so parasympathetic is going to decrease cardiac output. Sympathetic will increase cardiac output. Now, know that as far as with the fight or flight situation there, okay, the adrenal medulla, this is the core of the actual inner portion of the adrenal gland. That's nervous tissue, right? They're going to be producing this epinephrine, norepinephrine. And so as a result of the fight or flight situation, stress, excitement, increased physical activity, we're going to produce and kick out more epinephrine, norepinephrine. Intrinsic regulation of the heart, okay? So not other factors contributing to, but what's taking place as far as the functional characteristic of the heart itself, right? So the terms preload and afterload, the amount of stretch of the ventricular walls. So the stress that's placed upon the walls of the ventricles as a result of how much blood is entering into them, right? The greater the stretch, the greater the force of contraction, okay? Afterload, the pressure of the contracting ventricles need to produce in order to overcome aortic pressure, so blood will move into. So really, there's a situation where we have to have enough pressure pushing from the ventricle, created in the ventricle, pushing into the aorta for the valves, for the semilunar valves to open, and for blood to flow out of the chambers and into pulmonic and systemic circulation. When you think baroreceptors, think pressure receptors, okay? Baroreceptors, think pressure receptors. So they're located in the walls of the internal carotids. So recall in lab we saw the common carotids, and then the common carotids will branch. Now, internal carotid, it's going to go straight to the brain. External carotid, there's going to be other branches going on to temporal and such, and to other areas of the head, and the aorta. The input, recall when we were studying the nervous system that in particular the brainstem, the medulla oblongata, is going to be what's going to be controlling respiratory rate, heart rate, blood pressure. Very important factors are going to take place in the medulla oblongata. So these pressure receptors will send information to the medulla oblongata, which will in turn process this information and determine what needs to take place. pH and CO2 chemoreceptors located in the hypothalamus. And again, too, recall that when we were looking at the hypothalamus, such an important area, folks, right? Such an important area. And you're going to learn that really it's CO2 levels that are really what's dictating your ability to breathe, the stimulus for your need to breathe. Let me tell you this. I go into the water, right? Go into a pool, I close my nose, or I just stop breathing, right? Hold my breath, go under the water, okay? Now, as I sit under the water for a while, eventually you're gonna be like, oh, I need to breathe, right? You need to come up out. Well, it's not the lack of oxygen that's the trigger for you to want to get up out of the water and breathe. It's the increase in the concentration of CO2 present within your blood. That's what's really going to be the factor that your body needs to go, hey, I need to breathe so I can set off the CO2 and take in oxygen. Now, for patients who have emphysema and other types of pulmonary respiratory issues, O2 is the trigger. But for people who are healthy and normal physiology, it's the rise of CO2 that's really the trigger for the need to breathe. Okay, and so where are these chemoreceptors located? And know this also, if you have an increase in CO2 levels in the blood, you also have a decrease in pH or in acidity. Okay, so below 7, acid, right? So acidic environment. So pH and CO2 chemoreceptors present in the hypothalamus. So really a core, key, important area of the brain to allow for the basic functions of the body. Okay. So homeostasis, right? So an increase in, now, so think about this for a moment, please. So an increase in body temperature increases heart rate. You know this, right? You're exercising, you're working out, and you're not only just as a result of just the exercise itself, yeah, that will contribute, as well as the increased heat that the contraction of the skeletal muscle will increase your heart rate. How about even just sitting out at the beach, right? Sitting out at the beach in the sun and you're hot, that's also just that factor in and of itself will increase your heart rate. Okay? An increase of extracellular, right? Extracellular potassium will decrease heart rate. Folks, people are taking potassium, different types of potassium medication in order to decrease their blood pressure. So decrease the heart rate, decrease the blood pressure. Okay? Decrease in extracellular potassium can promote arrhythmias, fatigue, and there can be issues with like the arrhythmia with the heart rate and such. So potassium levels, very important, as well as sodium levels. So you'll see here, so the intima, the innermost layer, the media, and the adventitia, these are the layers of the vascularity and such. And know that the very innermost layer of blood vessels are continuous with the inner lining of the heart itself, the heart chambers. Okay, so the inner lining of the blood vessels are continuous with the inner lining of the heart chambers. So whether it's the atria or the ventricles, that inner lining is continuous with the blood vessels. Okay. And the lumen, we know that lumen is just the cavity where we're going to have the blood flowing through. Okay. And anastomosis, junction of blood vessels. That's also a good term that you know. Arteries, veins, capillaries in between. So the capillaries really, so it's going arteries, arterioles, capillary, venules, veins, right? Because then we have So arteries. So we have the aorta, right? We have the aorta going to the arterioles throughout systemic circulation to the capillaries. The capillary beds are we're going to have nutrient and waste exchange taking place. So gas exchange, nutrient exchange taking place, right? We're offloading oxygen, we're offloading nutrients, we're taking waste, we're taking CO2, we're taking waste products back into the blood via the capillaries, thin-walled vessels. Then we're passing through venules, then to the veins, and then to the right side of the heart, right? And see how you're just looking at and you're seeing that. So know that the arteries are more vascular, okay? And what's the muscle that's present? It's smooth muscle, right? Smooth muscle present. They're just, the arteries are more substantial and they're thicker and they're larger because there's higher pressure taking place within the arteries in comparison to, and connective tissue also, in comparison to the veins. Now, the arteries will not have valves present, but the veins will. See the valve right here? The veins will, because we don't want to allow for a backflow of blood. We want blood going from distal to proximal. Distal, right, the extremities, to our right side of the heart. Okay, so we want all that blood flow, and remember, right, high pressure, low pressure. Okay, and so the veins carry a lower pressure, and so as such, we want to prevent a backflow, so the valves assist in that. Okay, so again, knowing that the arteries are carrying this oxygenated blood from the heart to the capillaries, right? Except for, and we know the exception as far as the pulmonary arteries, pulmonary veins. Okay? We already know this as far as the aorta. Then the small arteries will branch into the arterioles. The arterioles will then feed the capillary beds. Okay, so the arterioles are bringing blood to the capillary beds. Capillaries are the smallest vessels, right? They're thin-walled, and they'll allow for then gas exchange and movement of nutrients back and forth in waste. So this term, selective permeability, right? So it's selective, and we've studied that term when we were looking at the plasma membrane of cells. So you need to know these different types of capillaries. Okay, continuous, fenestrated, sinusoidal. I should have. I think I have. I don't have images. Okay, so we'll have to. I believe if you look at your Scott and Fong text, you'll be able to see images of these vessels. Okay, so continuous capillaries, no gaps or fenestrae. These openings, these windows, these allowing for nutrient, whatever it is, to pass through very easily, they're not there. So no gaps or fenestrae. Least permeable muscle and nervous tissue is where we have these type of capillaries. Okay, fenestrated. So we have these pores, right? These openings, highly permeable, present now. So where would we have this? So in the intestinal, in the GI tract, right? Intestinal villi, choroid plexus in the brain. So the choroid plexus in the brain, right? What are we doing? We're actually producing with the ependymal cells, we're producing CSF, cerebral spinal fluid. Ciliary process of the eye. So we're involved in actually then also producing the aqueous humor and such. Glomerulus of the nephron. So this is where we're actually filtering blood and producing filtrate, which becomes urine. Okay, so that's where these types of capillaries that are highly permeable, they fenestrated, that's where they are present. Sinusoidal, large diameter and large fenestrae. Think the endocrine glands and such. So think in particular, like a very vascular gland, highly vascular, would be the thyroid gland. Okay, and you'll see if you look at the models, you'll see that there's a lot of blood vessels present for the thyroid gland. Right. So let's do this. I'm going to take a break at this slide right here. So we'll take a break at this slide right here. So we'll begin on this slide next. So we're going to take a 5-minute break. So I'll see you all back at the computer here in 5:40. Okay, that's in like 6 minutes. Okay. All right, folks, and then I'll begin when I come back from the break, asking you any questions that you may have. Very good. Okay, everyone, so I'm back. We're going to begin finishing up our chapter here, or going through at least a little bit more. So are there any questions at all or any comments at all? I saw Kelly there. Good spot, good job as far as mentioning, as far as like a person with diabetic ketoacidosis, their blood would be acidic, and that is correct. Yes. So, okay. Anybody have any questions or comments at all? Good. All right, folks, let me hide everyone again. We'll go back into sharing the screen with you all. All right, so let's take a look here as far as the venous system here. So the veins are concerned, so carrying deoxygenated blood. Again, we know that the uh, pulmonary veins are carrying oxygenated blood. That's the exception to the rule, but throughout the whole body, throughout systemic circulation and the coronary circulation, veins are carrying deoxygenated blood. Again, the walls are much thinner than the arteries. They don't have to withstand as much pressure. We know that, mentioned that earlier. Okay? And they have valves. We talked about that. And so the valves are ensuring one-way flow of the blood from distal to proximal to the right side of the heart. Okay? And we talked about also, I didn't mention this, but you know that, and you can see, excuse me, the vena cava is the largest vein within the body. And knowing that also, and you can see it by just look in the lab when you have opportunity and looking at the flat model of the human body and looking at the different vasculature, seeing that superior vena cava bringing blood from the upper part of the body, inferior vena cava bringing it from the lower part, the inferior aspect of the body, to the right chamber, upper right chamber, the right atrium. Okay? And the valves, again, allowing for this continuous of one-way blood flow. Now, know this, and this is important, that as far as circulation is concerned for the cardiovascular system, for blood, as well as for the lymphatic system, the contracture of skeletal muscle, very important in order to enable and allow for the flow of the blood to the heart and going from the extremities to the core and into the heart, as well as for also the lymphatic system, the movement of, and know that the lymphatic system is not, it only will, it's not a direct connection to the pump, to the heart itself. So with the lymphatic system, we just have these blind blind lymphatic vessels that are receiving the filtrate from the blood, from really not filtrate, really it's the plasma from the blood. They're kind of like sucking it up, taking it up into the lymphatic system and lymphatic vessels, and then as a result of movement, as a result of skeletal muscle contraction, we're allowing, and also valves, we're allowing for lymph to then also drain into uh, the venous system. And we'll see that in a couple chapters. So pressure changes that occur also will help to contribute to this bringing of the blood from the venous circulation into the right chamber. Also, look at this as far as stationary positioning can decrease flow back to the heart for oxygenation. It can cause drowsiness. So that's a big deal. So having our patients not be so sedentary and having our patients that are bedridden to do some type of movement, right? Very important to keep movement. Movement is life. I'm going to tell you that right now, and I'll tell you that as far as one of the most important things that you should keep in mind as far as being a clinician and working with patients is realizing that when there is no movement going on or minimal movement, that really leads to lower quality of life, but also then also leads to a process where you're going to have issues with blood flow, lymphatic flow, digestive movement of nutrients throughout the body. It can really, movement is life. That's the key issue there. As far as blood pressure is concerned, I'm going to provide for you all coming into lab on Thursday, this Thursday and next Thursday. I'm going to provide a note packet for you all. I also have posted a note packet for the heart as far as heart pathologies are concerned. and we'll talk about that, as well as the blood pressure packet that I'll hand out to you. It's only a couple pages for both of those, but they're just additional notes that can help you have an understanding regarding the pathologies and also blood pressure itself. So systolic and diastolic pressure, right? We're going to talk about that, as well as what is pulse pressure and the values, okay? So the pulse, we get an idea of what's going on with the pulse. Alternating expansion and contraction of an artery as blood flow through it, and so we can actually palpate that, we can touch that, we can feel it. You can do it yourself right now. I'm palpating my radial pulse right now. You can feel that pulsating beat, right? And there are multiple areas throughout the body that you can actually do this and feel this. I think, did I provide an image? Oh, okay. I can provide an image for you all too regarding the different pulse points that can be palpated throughout the body. And you'll see here, as far as can feel the pulse on the body where the artery is near the surface of the skin and over a bone. And so you'll call those pulse points. So brachial, right? So for the brachial artery, you'll see it's more medial, right? Common carotid, femoral in the inguinal region. Dorsalis pedis would be, or the dorsum surface of the foot. Popliteal would be in the posterior aspect of the knee. The radial artery, as far as that's an easily palpated near the thumb, right? Temporal arteries, right? So you can just place your fingers, the digits right up on the temporal region, and you can feel a pulse. Pressure points can be used to stop bleeding, distal to the pulse point, and so very important as far as let's go back here. No, here we go, right here. Next one. No. There we go. The femoral artery, that's what I was looking for. So if there's an injury to one of the lower extremities, right? So pressure upon the femoral artery, which is bringing quite a bit of blood to the lower extremity. It's really important. If you can put pressure there, you can minimize the amount of blood that's being lost through a wound in the lower extremity. So just something to consider. And the effects of aging, right? So really, what's going on? The connective tissue is going to be affected. So arteries become less elastic. Issues with just the musculature, they can become dilated, elongated. How about this as far as for the veins? Can you see as far as issues with the also dilation of the veins and issues where the actual varicosities, the valves are not performing like they should. So you'll end up having veins that get enlarged, and they just look pretty bad because we're having an issue with returning the blood to the heart. Okay? Systolic blood pressure increases due to reduced elasticity, right? Sadly, so the blood pressure is going to rise. Baroreceptors become rigid and less sensitive, right? Baroreceptor, pressure receptor. So as a result, postural hypotension. So this orthostatic hypotension, it's a matter of, so a patient is sitting down and they stand up, and if they do it quick enough, what will happen is that, and as a result of the aging process and as a result of those pressure receptors not functioning properly, they can get very lightheaded, and this can be a problem. Can correct many congenital heart defects. That's interesting as far as, So we can correct these heart defects. So congenital heart defects would be issues that we're looking at, like the tetralogy of Fallot, issues where there's communication between the atria where there shouldn't be. There could be also other openings in areas where it shouldn't be as a result of fetal circulation that has not been fully blocked and closed up. Those can be issues. Issues also like valve issues. These terms here. Now I have, I said, my note packet that I've given to you all that I'll be giving, not only just regarding the heart as far as different disorders are concerned, but also as far as blood vessels are concerned. So, and aneurysm, arteriosclerosis, atherosclerosis. So plaquing when you're thinking of the athero. Plaque accumulation in the arterial walls. This is leading to issues with the blood vessels do not have the ability to expand. They're going to actually become more rigid, and that's a problem. So then leading to arteriosclerosis, so thickening and hardening of the arterial walls, which can lead to an increase in pressure, and also lead to issues where we can have plaques that can come off and enter into circulation, which can then become a blockage, a clot. This can be a problem as far as blocking small vessels. Now, if this is an issue within the heart, and the brain, and the lungs, it can be catastrophic. Aneurysms, and I believe I said this to one of the labs, and I don't know if I said it to both labs, but in particular, you're thinking of AAA, abdominal aortic aneurysm. So on the lateral view of an X-ray, you can actually, and as a result of a finding that we would see many times in practice as far as a chiropractor is concerned, we'd order lateral views of the lumbar spine to look at what's going on with the low back vertebra. And we do a lateral as far as an A to P, anterior to posterior, lateral, and we would see on the lateral view sometimes plaquing. And it would be important to notate the plaquing anterior to the vertebral bodies of the lumbar vertebra and thoracic, lower thoracic, because then we can actually see what's going on with the abdominal aorta. And if there is an aneurysm present, if there is an expansion present of the vessel, and then a rupture of an abdominal aorta, a rupture of this expansion of the actual blood vessel, can be a catastrophic situation as far as the patient bleeding out and into their abdominal cavity. Terrible. Gangrene, as far as tissue necrosis, this is areas, and it can be as a result of different types of bacterial infection. It can result as a result of complications from diabetes, wound healing, improper wound healing, or lack of wound healing. Phlebitis, right? So we think inflammation of a vein. That's when we think of the itis inflammation. Phleb, the word root there for vein. Inflammation of a vein due to a blood clot, not a good thing, right? An embolism is we have this clot obstructing a vessel, right? And so really, know that you can have clots break off from a vessel. They start traveling, then they go to another vessel that's smaller, and they can block that vessel, and this can be tragic consequences. Varicosities, I mentioned earlier there, as far as damaged, twisted veins. The valves are an issue, so we're not allowing for one-way flow of blood. It's actually then backflow of blood, and then it can lead to these veins becoming more of a storage of excess blood, and it's not a good thing, and it can be very painful actually, varicosities. Hemorrhoids, inflamed veins in the rectum and anus, and this can be as a result of patients cleaning themselves and seeing frank red blood. So really red blood. You think that there's something more at the distal end of the digestive tract in comparison to more of a darker brownish color, which could be as a result of darker black color present within the feces, which would be blood that's deep within the digestive tract, and that's not a good thing, not a good sign. Cerebral hemorrhage, so we're talking about a brain bleed here. So as a result of trauma, as a result of an aneurysm that's been ruptured, so we have here expansion of a vessel that's been ruptured. High blood pressure can also be an etiology, a cause of a cerebral hemorrhage. This is life-threatening. PVD, peripheral vascular disease, narrowed vessels as a result of atherosclerosis. So this plaquing taking place within the vessels, which can lead to reduced blood flow to the extremities, and exercise can exacerbate this. And so patients exercise and they're going, oh my gosh, I'm really having an issue here with my lower extremities and my ability to exercise and such. And this can be as a result of the plaquing present within those vessels. Hypertension, right? So we really, as far as normal and healthy blood pressure, want it less than 120/80, right? Systolic is 120, 80 is diastolic. Prehypertension, we're looking at between 120 to 130 over 80 to 89. And then stage 1 and stage 2, we're looking at 140 to 149, that range, and 90 to 99, that range. And then stage 2 hypertension is to the ends, we're at the point where very serious and of concern. Really, stage 1 and stage 2, both of very concerned and need to be treated. White coat hypertension, you've probably heard of this. The patient goes to the doctor's office or goes to the clinic, and they get anxiety as a result of being there, and their blood pressure just rises as a result of the anxiety they're experiencing. Hypotension, this is a situation where we have lower blood pressure, and you would think, oh, lower blood pressure, that's great. Well, if it's pathological lower blood pressure, as far as a pathology is concerned, a disorder, so it's not a good thing, because patients who have hypotension and are not athletic, right, they don't have lower blood pressure as a result of training and exercise and such, they're experiencing fatigue and tiredness and just having a rough time of it. TIAs, these are like we would call them mini strokes. Have you ever heard of that before, right? So a stroke would be a CVA, cerebral vascular accident. TIA, transient ischemic attack. These are mini strokes that can lead to a CVA down the road. And again, too, giving it's giving the clinician the insight that this patient is on the road to a CVA and a very bad situation as far as potentially catastrophic outcome. Oh, shut this off for a moment here and come to stop sharing. Megan, I have a really bad white. Do you really? Okay, Megan. And my doctors always freak out when they think I'm sick. It's weird, but I've almost been sent for testing because of it. They just won't listen to it. Understood. Because so Megan, let me ask you. So Megan, have you taken your blood pressure at home, and it's at a decent level and such?
I take it at home. I take it in school because I'm also in like the health science program for my school. So we take our blood pressure all the time if we're bored. I'm always normal. I'm also an athlete. So like they're just not getting it that I am very anxious at the doctor's office. So
wow, yeah. So it's a real thing. It truly is. Yeah, thank you for sharing that. That's good. Thank you. All right. So let's see here where we're at. Okay. All right, I'm going to stop here, folks, for today, and then I'll just finish up next class, and then we'll get into the next chapter. So let's do this. So I stop sharing my screen. I'm going to turn off the recording.